Good evening, everybody. Thank you again for coming here tonight. Welcome to our very first program, like I said, in the state of Pennsylvania. And I want to thank you all again for being here today. And I do have to thank Sanofi-Genzyme and Biogen because they are our primary sponsors of tonight's program. And we all want to give them a round of applause, please. So we are doing a different type of program here tonight. We are not speaking about a medication. We are here to talk about wellness. And we're here to let the two clinicians that are here speaking tonight, and they're going to talk to you about a variety of different topics that probably will greatly influence at least a few of you in this room, okay? And we're going to let them do it was supposed to be a round table, right? But the hotel didn't have a round table, so we're now having a square table discussion, all right? I hope you're all okay with that. All right, next we're going to have Dr. Daniel Kantor and Carol Chieffe from the local area, and I want to read something to you about both of them because they're going to come up here and do this, remember, this square table discussion, all right? Square round, right? So Carol Chieffe is a RN at Allegheny MS treatment since 1996, launched all MS medications but bedasterone, passionate advocate for MS patients and families. Hi.
Oh, I figured it's Halloween.
How are you? That's good. I forgot to wear my hat. Maybe they'll see me later.
All right.
That's my Batman, right? All right. He could be a Batman for all of you because he does a great job with it. All right. Thank you, Carol. So we're going to see you in a moment. Now about Dr. Daniel Kantor. He's past president of the Florida Society of Neurologists, founding president of the Medical Partnerships for MS, proud member of the MS Medical Advisory Committee of MS Views and News, and not only that, he does around the world with MS for MS World, which is also here in Pittsburgh. And he doesn't like to talk about it, but you guys got to see him on his channel. He does talks that, yes, MS around the world. He's at the MS conferences that take place all over the world, learning about the research going on all over the world. He's part of that research, and he has great things to talk with you about on a regular basis. But today he's going to talk about what we would like him to speak about. So I'd like to invite the two of you up here, all right? And if you would like to come on up, they're going to have a conversation with themselves, all right? That's what this program is about. They're going to sit here and they're going to talk about topics that we gave to them. You're all going to listen to the topics that they're speaking about. They're going to talk to you for about 40 minutes. And after the 40 minutes, I'm going to run around to do another Q&A. Please listen to everything that they are going to intimately talk about with each other, okay? And that's it. It's for you, but they're going to be speaking with each other. Thank you.
Well, thank you so much for having us. I hope yins are doing well. I am a Pittsburghian, not by birth, but by marriage. My wife's from Uniontown, and I'm proud that one of my nephews is right here. He's from Uniontown, a good wrestler in high school, and hopefully soon in college. So I want to thank you guys so much for having us. What we're going to talk about today is about something that's really timeless and really geographicless. The idea of comprehensive care in multiple sclerosis, but even deeper than that. What does it mean to have an MS team? Sometimes you hear terms where we talk about your team, but what do we actually mean by that? And that's why I'm so happy, I'm so happy to have Carol Chieffe here, who's going to give us that inside perspective of what happens from a nursing perspective when you have an MS certified nurse. What does that mean, the MS team? People here may have heard of it. They may have heard the concept that there should be a team approach, but what do they really mean? So let's just start with that, Carol. What do we mean by an MS team?
Well, a lot of times when a patient comes in to see the doctor, they kind of forget to bring someone with them, or they forget what the doctor said, or they're afraid to ask him, I don't understand, could you explain that? So they go home and they call me on the phone and say, okay, this is what he said, what does he mean? From my perspective, I make it easier for people to understand and try to explain to them that it's okay that if you don't understand, when you're in the office in front of your physician, to say, could you let me understand that a little bit better? So I also can bring to the physician a lot of times real world experience. the physician has so much more knowledge scientifically and looks at things, but sometimes they forget little things, as in, they're not going to tell you, but they haven't taken that shot in 100 days. Where they're afraid to tell the physician, but I can tell you and let you know that we need to come up with something better.
And that's really this idea, when medicine and nursing really feels that people who aren't in healthcare think of them as the same thing.
Right.
You go and you see your doctor or nurse. We come at it from very different perspectives. Things are changing. Medicine is luckily and thankfully becoming more like nursing. And nursing, I think, scientifically, it's good that nursing is becoming more like medicine. There's stuff that we can share. This idea of really placing the person with the diagnosis at the center of the team is so important. And that's why a little bit over 10 years ago, I came up with this name for it called the Multiple Sclerosis Team Approach Rule. The basic idea is very, very simple. The basic idea is that the center of the MS team is not you, not me, not the spouse. The center of the team is the person with MS. Notice I'm very careful about the words I use. And you won't often hear me use words like patient. I do use it sometimes. But the real idea is that it's a person with multiple sclerosis. A person with MS has what I think of as a lifetime diagnosis. I don't use words like chronic or lifelong. Lifelong makes life sound long and arduous. Lifetime is like the cable station by a similar name. Even when you turn off the cable station, guess what? You're still paying those bills in the background. It's still going on. Even when you're not focusing on your multiple sclerosis, it's still going on in the background. You still have to pay those bills. You still have to think about what you can do to proactively change your future. And not everything that we do proactively to change the future involves medications. True, and then Jeff did mention it, since 1993 we have had disease-modifying therapies. That has changed the face of multiple sclerosis. Are they perfect? No. Are they right for everyone? No. Are there some serious side effects with some of the newer medicines especially? Absolutely. But we have changed what's happened in MS. Do you know that when our first medicine came out in 1993, anybody know what that medicine's called, by the way? Yes. Beta-seron, or in the rest of the world called beta-feron. And now in 2017, at the end of October, we have 13 separate branded products, 1 branded generic, and 2 unbranded generics. That's an amazing leap forward, faster than everything in neurology and most things in medicine. Does that mean we're done? No. There's still a lot for us to do. We have to get better at treating progressive MS. We have to get better at repair. We have to start thinking about the C word, start thinking about cure, start thinking about these things. We have to get better at being able to follow someone and be able to predict how they're going to do. But have we come a long way? Yes, and I think we should recognize that. But medication is just one aspect. We've heard a great talk by Jeff, inspirational as always, where we talk about how exercise can be important. Diet can be crucial. You know, I was looking on Google today and I think I typed in the word fatigue, I must have, because the word fatigue appeared. Maybe it's because I'm still tired from flying from France, where we just had the 32nd annual Congress of the European Committee on Treatment and Research in MS, and so I'm a little bit still on French time. But I searched it and it showed an image, and that image showed a person that had a label on top of her head and it said chronic fatigue syndrome. And you know what she had right there in front of her, the food? A hamburger. I know why she had chronic fatigue syndrome. Because she was eating gluten and eating red meat and probably not exercising and other things going on as well. So there are things we can do in our diet and things that we can do in our exercise that can help us get out of all that.
And another thing is the water issue. So many people with MS just don't want to hydrate. They're so afraid to hydrate. The number one reason that you're tired is dehydration. We have to learn to drink water.
But Carol, this is actually an important example of where doctors and nurses can really work together on this, because the doctor won't realize that the person in front of them isn't drinking. And they especially won't think to ask the reason. You know the reason. The reason the person isn't drinking is because then they'll have to pee.
They have to pee. MS patients don't drink because they might have to pee.
And I noticed when you mentioned doctor, you used the pronoun, you said him.
And that's only because I work with HIMSS.
No, but you're right. 75% of neurologists are over the age of 55. And while the newer generation of doctors are actually more women than men, reflective of the general population, still, the population among neurologists is still predominantly men. People with MS can be men, can be women, but 2/3 of them are going to be women. And so a woman may not feel comfortable coming into my office and talking to me about bladder control. May not feel comfortable, especially the first few visits, talking to me about relationship. I was being careful because Jeff said because of the kid in the back of the room, about relationship issues. And so we do have to recognize where we're coming from, in terms of these different aspects.
Right. You do. And, I wouldn't expect a physician that's male to really know about depends sizing, where a woman, we know more about what size underwear women wear.
It's a perfect example. And so when you're thinking about this team, before we start talking about lots of different layers of the team, just think the person you're seeing, the doctor or nurse practitioner or physician assistant, that person who's one of the core people for taking care of your multiple sclerosis, needs to surround themselves and surround you with other people as well. So when I think about the M-star, I think about a star, I think about the person with MS in the middle, and on one side you have all of us who aren't really that crucial, but oftentimes you'll think of us as the center. So the MS doctor, the MS nurse practitioner, physician assistant, the physical therapist, occupational therapist, speech and swallow therapist, case manager, social worker. We are important consultants, but we are not living your life. We're not in your homes, and we are not the center of the team. We are there to be there to help support you. But just like if you were trying to get your taxes done, right? You would have a tax team.
Right.
The tax accountant or tax attorney would be really important. Would you ever go and talk to your accountant without bringing in your W-2s?
Absolutely not.
You always bring that in. Yet people come to our office all the time, and I say, well, what medications are you on? They're like, well, that little yellow pill. Number one, most pills nowadays, 80% are generic, which means they're white and they probably change color month to month and they change size because they're made by different manufacturers. Number two, we never learned the color of medicines in medical school. And number three,
Nor in nursing school.
Nor in nursing school. Number three, what that means is that time that could have been spent talking about you and the things that are important to you every day of your life, instead we are wasting. We're not wasting our time, we're wasting your time. We're wasting it on talking about which medicine. How many people here carry a list of their medicines with them? Whether you have MS or not. It's a pretty good group. How many people is it typed out? Typed out. Typed. Like where you print it on a piece of paper. Not just in a smartphone. As we know, the federal government cannot break into your smartphone. MS does not protect you against car accidents. Any of us could be in a car accident at any time of our lives. Where are the emergency medical technicians going to go? They're going to look for your identification. Opposite your ID should be your list of medicines and your list of allergies. And it should be typed out because guess what? In Catholic school, they slap your hand if you write too messy. You know what they do in doctor school? If you write too neatly, they start slapping your hand to make sure that has to be. But we're not the only ones with poor penmanship. And so the idea is you have to change things over time. Medicines do change over time. It's much easier if you just go to your word processor and you just go and you hit print and that's the copy you have. If you just have it on your smart device, then what's going to happen is when there's no electricity, guess what? That smart device ain't so smart anymore. And also, when you go to your doctor's office and the nurse or the medical assistant want to scan in your medication list, they can't scan in a computer screen. They can't scan in that smart device, that mobile phone. So make sure you have it printed out. If you do that, you have saved automatically 15 minutes of time. And 15 minutes of time is the length of many people's office visits if they're lucky. Anybody notice that over the last 20, 10, 15 years, there's been less and less time? You get less and less time in the office, which means you have to maximize it. So, Carol, what do you think people can do to maximize the time they're having?
Well, I always tell people to bring someone with them And the three most important things that is bothering them or they want to be discussed need to be brought up. You don't need 1,700 different issues to just talk to your healthcare provider. You need the three most important. Because what happens if you have too many, then the three most important don't get handled, and then you go home and you realize, I forgot to tell them or ask about this.
Carol, that's
Write it down.
That's an important point, because people might say, but wait, I have 1,700 issues. The thing is, when you offer the doctor 1,700 issues, the doctor is going to choose which are the topics they want to talk about. Instead, this is your office visit.
Right.
You decide on the narrative. You decide on what we're going to talk about. If you bring up 3 issues, it's very hard for me to squirm my way around it. I'm going to have to talk about those 3 issues. And please do not bring up the one most important issue when my hand is already on the door and I'm walking like a parallelogram, like Jeff said, I'm walking out the door, because that is generally the most important issue and the most private issue. Bring up your topics actually before we bring up ours. I don't know, Carol, if you ever give that recommendation, but no matter what, your doctor is going to get through the questions they have for you. Some of the questions are because of the federal government. Some are because of your state government. Some are because of your county government. Many are because of your insurance company. Some of them have to do with MS overall, that we may ask everyone, and some of them have to do with, I've written to myself what to ask you next time. That's a lot of things. If you wait for me to be done, I'm already thinking about the next person. I feel like I've done what I wanted to do. I brought up all these topics as a doctor. I'm doing a great job. I'm meeting all the quality measures that the government wants me to do. But I haven't done the most important quality measure, which is addressing what's important to you. So don't let me get on that list. Start out with what's important to you.
Absolutely.
And what Carol said is write it down, because you're not going to remember when your lights are in your face, when you're there at the office visit, the person's wearing a white coat, they're using fancy words, they're doing all these things, they might have a medical student or a resident there, they're waving their hands, and you have to then try to remember, what's that word I'm looking for? Instead, write it down beforehand. There is nothing like the power of the pen.
Absolutely. You write it down. And then they have to address it. And don't, as soon as they come in and say, how are you? Your answer is, I'm good, but I have these 3 things I need an answer for. It's your turn first. And just like I've told people before, if you had a plumber come into your house because you had a clogged drain and he wants to replumb your house and never addresses your drain, you're not going to hire that plumber. If you go into your doctor's office and have the 3 most important things that you want to discuss, bring them up, and that they don't get discussed, it's time to find a doctor that will discuss them.
And that's an important point Carol brings up. If MS is really a team approach, and you're like the general manager, you're taking everyone and you're figuring out who should be in which positions and all that sort of thing. Well, if something's not working out with one of the members of that team, sometimes you may need to replace them.
Absolutely.
I know a lot of couples that go through couples counseling. I don't know any doctor-patient relationship where they go through actual counseling to figure out, but at times things can be broken. Some things can be fixed. Sometimes your doctor's having a bad day, you're having a bad day. Things can happen. But it's a good idea to be frank and to figure out, well, is this just a one-off thing that's going on? Or are there real issues here where there's just personality conflict? Or they're just not supplying you exactly what you need. So there's several things that can happen during the office visit that can alert you. One of them is if you see this really ugly red Pac-Man called jargon. Jargon is a fancy word that means fancy words. It has absolutely no place in the office. It has no place coming from me, coming from her, or coming from you. You might say, well, wait, I sound like a smarter patient. I use the word patient. I sound like a smarter patient when I use fancy words because then I'm speaking the same language as the doctor. Nope, it's not true. How many people here have ever gone in to see the neurologist and said, I have neuropathy? I see people all the time who walk in and they say that. What they're trying to say, I think they're trying to tell me they have pain. I'm not sure. Because the word neuropathy is a very technical term. It means neur, like nerve, pathia, like pathological. So you're actually right if you have pain and you say I have neuropathy because your nerves aren't working right. But a neurologist does not hear that when they hear the word neuropathy. A neurologist hears peripheral neuropathy. We think of MS as being a diagnosis affecting the central nervous system. So when somebody tells me they have neuropathy, I think peripheral neuropathy. So I think not MS. And when I hear peripheral neuropathy, the top 3 things I think about: diabetes mellitus, diabetes mellitus, diabetes mellitus. You don't even have diabetes, but I've just spent 10 minutes thinking about diabetes. You don't want me thinking about diabetes. You want me thinking about your top 3 issues, not somebody else's issues. So when you use fancy words, you think you're helping us, but there's a very good reason why your neurologist may drill down. Some of us are very into language and will really drill down and say, what do you mean? And we'll ask you from 5 different ways. We're not trying to be annoying. We're trying to really understand. I've had people who tell me that they have numbness. I don't understand what numbness is. I don't know if they mean tingling, if they mean less feeling, no feeling. I've had people who have weakness and call it numbness. I've had somebody who had a tremor. Their hand's doing this. And they say, yeah, can't you see it? It's numbness. You don't see the numbness? I would never have thought, except that they pointed it out and said, that's what I'm talking about when I say numbness. That's problematic. That means we're not using the same language, and we're all talking about people who are having native English speakers. Imagine if we're trying to do this across different languages. It can be very, very difficult. And so you want to make sure that jargon does not enter the room. It means you have to be responsible, but if you see your doctor trying to use too much fancy words, they may be trying to cover up something else by trying to use fancy words. They may be trying to sound smarter than they think they are. There's no need to use fancy words. We're all human beings. Why can't we talk to each other like human beings? That's why I love Pittsburgh so much.
Oh, yeah. We are definitely down to earth in Pittsburgh. Another thing that seems to come up a lot is a person with MS, or even sometimes persons with MS friends or spouses, significant others, will say, well, I read it on the internet. It said this. Can you expound on how sometimes that's not the best thing to come up with?
Well, so the world's most famous doctor is Dr.
Google.
Yeah, it's not Dr. Seuss, Dr. Google, and Dr. Google never gets sued, by the way. So when you type in anything you type in, you're going to find multiple sclerosis on Dr. Google, which means the internet is beneficial. It has allowed a lot of things to happen, including social media. We've sent out, and Jeff might not like the pictures that I sent out of him on Instagram and on Twitter and on LinkedIn and on Facebook. His family might appreciate them. But it's allowed for social media. It's allowed for a trialogue and a quadrilogue and much more than a dialogue like never before. But the internet also has some problems. And those problems usually come because a well-meaning family friend or family member read something on the internet. So part of your job also is to give due diligence. Say thank you for that information. Then do your own research. Bring that information to your doctor when you go and see them. We are there as consultants. If you're not bringing to me information that you read on the internet, that means you're either not admitting that you have multiple sclerosis to yourself, because if you admit that you have it, then why wouldn't you search the internet for it? And why wouldn't you have questions when you come in to see me? Or you just don't feel comfortable talking to me, and then we have a real problem. So you should be bringing those questions, and your doctor shouldn't just be dismissing them. They may dismiss them because the information that you looked up is just something that we've heard so many times and has been so problematic for us. I'll give you an example, bee stinging. Bee stinging does not work for multiple sclerosis.
Okay. Or if you see, and there's one provider here in the area that does CCSVC, I think those are the letters. But he also tells anyone who sees him, don't tell anyone you had this done. I really find it concerning that you're seeing a physician and he's telling you not to tell any of your other physicians that you had this done. I really want it to to impress how important it is that the team that cares for a person with MS isn't just a neurologist, the MS nurse, the physical therapist. It's your primary care. It's every other physician that you see. And it's important to share that information with that whole group.
You work in a large healthcare system.
I work in a very large healthcare system, yes.
So the communications may be different than people who aren't going to see people, or they may be part of that system but not their primary care, or not their cardiologist, or not their neurologist. So different people may. What advice do you have for people with MS about how they can make sure that their team is actually communicating amongst itself?
Well, it's important to remember, especially in our area, we have two very unique healthcare systems that don't share information back and forth.
I know, I've seen the commercials on TV.
Yes, very unique. It's important for the person who wants this information shared to remind whatever physician or provider they're with that day, please make sure my primary care physician knows this, my neurologist knows this. It is the days of computers, and it's very easy to send, but it doesn't get sent outside of the system unless you ask for it to be sent outside of the system. And no, we can't see each other's systems.
The idea of communication is so important. Imagine trying to have a football team. And, imagine the Steelers trying to play, but actually they just don't talk to each other, right? So the quarterback is playing, he's not talking to anybody he's going to throw the ball to. You're not going to be a very good football team. You want to have the best possible MS team. And that means you want that team communicating amongst itself. But that communication starts with you. It starts with you before you even go there to visit that doctor or that nurse. When you're at home, what you need to do is sit down with the people closest to you, with that loved one, with that spouse, with that care partner. This is MS. This is not Alzheimer's disease. It's not a caregiver. It's a care partner. When you hear care partner, what advice do you have for people to create a true partnership?
Well, you have to be honest, and you have to share with that person, and it has to be a give and take. You can't just expect that person that's your care partner to know how you feel, to know what you're doing, what you should be doing or shouldn't be doing. It needs to be an honest and open communication back and forth. And a lot of times I tell people with MS, it's important for their care partners to sometimes point out to them that, you seem more angry than normal. You seem more distressed or anxious than normal. When a person's going through that themselves, they don't see that. Your care partner is not telling on you, but wanting to work with you and make things better. It's important for them to report that to me, the nurse, to the physician, to someone. That's part of being part of the care team. Identifying things that maybe the person themselves can't identify.
Well, Carol, maybe it could be instructive and helpful if you give me an example of really great care partnership you've seen and really poor care partnership. Obviously, we're not talking about individual people and change the stories a bit, but give us that basic idea. What makes for a really model care partnership?
A model care partnership is a person that listens, a person that provides information to the healthcare team, listens when the person that's there that is being evaluated, and adds input. The sitting in a waiting room doesn't mean somebody took you to a doctor's appointment. That person needs to come in. The other thing that I've had many distressing things with I have very good care partners, but if a person is withholding something from you, such as putting your cell phone on top of the refrigerator and you're in a wheelchair, that's not a good partnership. That needs to be reported to someone in your care team. Or keep people that restrict their fluids because you might have an accident or have to need help in the bathroom. That is not a good care partner. You need to report that. And if you're anxious about it, then that is the one day that care partner sits in the waiting room and doesn't come in. but you need to be open and honest with your healthcare team. And sometimes it might be not even at that appointment, but before the appointment. Make a phone call, let them aware, and then someone in your team can bring that up. Have you ever had when that person is sitting right there and they understand that you now know?
A care partnership is so important. 1 in 5 Americans has some sort of, I'm going to use the word chronic, has some sort of chronic illness. And that's not to even mention chronic financial illness, which means MS is just one example. It's not the most common by far. Chances are your spouse or your loved one has something else medically wrong with them. Just because you have MS doesn't mean that their heart's working the way it should or their lungs are working the way it should. So at different times, when you go to their office visits, you'll be in that role of that partnership.
Absolutely.
If it's not give and take, it feels like one side's always giving. It doesn't feel good for either side. It doesn't feel good to always receive, unless you're, as Jeff was talking about, a child. Otherwise, it doesn't feel good to always receive, and it doesn't feel right to always give. You really need to have this idea of a give and take, and really a push and pull to make it work. But Carol brings up an important topic, which is that care partnership discussion doesn't start just at the office visit. It starts well before. I really recommend preparing for the office visit. How do you recommend people prepare before coming in?
Well, I like them to, as I said earlier, write down the 3 most important things. But I also want them to write down things that be honest about it. Look back. And I'm going to be honest, I have a chronic illness. I have hypertension. I have to make sure that I remember to take my pills. It's important for anyone going to their healthcare provider to look back. Have I been taking my medicine like it's supposed to be? That's important. We need to know that. Make sure that everything that was to be done before your visit is done. Your MRI, if you needed an MRI, we would really like to see that when you get there. Have it done. Have your lab work done. That's really important that that is done beforehand if you want that discussed. If we don't have the results, we can't get it done. So it's important to follow up between the 2 appointments. What was ordered the last time is done in advance.
If we're going to be really practical, I actually think that everybody should know their date. Hashtag know your date. What I mean by that is the date that your prior authorization is needed.
Absolutely. Or the day that your prior authorization is over. Insurance companies, I'm in charge of prior auth. Insurance companies don't call me and say, oh, by the way, Mrs. Smith's authorization is going to run out next week for their medication. If you don't have, I usually find out after the fact. You can't get your shipment, and then I find you don't have your lab work. I can't get that without your lab work. Know your date's a great idea, and write that down. Just like know the date that your MRI authorization expires. Don't call us 3 days later after it expired and said, can you get that? Insurance companies really frown on that you didn't have it done in the 60-day window that you were given.
Knowing your date is so important because sometimes people think that, well, the date I need to know is when I need a refill. That's not how things work anymore. There's not just the date of refill with the pharmacy. That's an easy date. It's the date of the authorization, the permission to go ahead and get the medication. If you don't know that date, what happens is you end up calling up the pharmacy and saying, why isn't my shipment here? They say, well, because you need your doctor to call. So then you call your doctor's office and you say, well, I need a new refill. Because you don't really understand what they're saying to you, which is you don't need a new refill.
You need a new authorization.
You need a new authorization, which means what you should have done is if it's April and you know that in May you're going to run out, what you should have done is seen your doctor in March. You see them in March. They then have seen you because they haven't seen you for a few months beforehand, and you tell them, I'm going to run out of my prior authorization in 2 months' time. That gives them plenty of time instead of calling them and asking them to do something backwards. Because doing something backwards means that you're missing your medication or missing your therapy for that time.
we're not being mean and nasty when we say you didn't get your lab work done. These safety labs are requirements to get that authorization. And you made a great point. When you call the specialty pharmacy and they say, well, you need the doctor to authorize it, they don't mean a refill. They mean an authorization. Many, 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 many times, I end up just doing double work because they call in, a patient will call and say, I talked to my pharmacy, I need a new refill. And it's an authorization. And by the time that comes around, what it really was worked out, 4 days have gone by.
So that's a perfect example of why jargon is dangerous. The word authorization to me is a fancy word. We didn't go to school to learn about words like authorization for medications. Did you learn that in 8th grade, 9th grade, 10th grade, 11th grade, 12th grade, college? No. We didn't learn it in medical school even. So we're using these words and we're just throwing them around, and then we might get confused. We might use the wrong word. So instead, you should be very clear when you're talking to both your doctor's office as well as to the insurance company as well as the pharmacy. What is it exactly that's needed and why? And then you write that down, and then you can repeat that so that your healthcare providers can know what's needed to move forward. So when we're thinking about all these things, what we've talked about a lot now is this one side of the M-star. There's a whole nother side of the M-star. And that whole other side are the people that are a lot more important. It's a significant other, the care partner oftentimes. It's the friends and family. It's the community. And oftentimes, community means religious community as well. Why are those parts of the MS team so important, Carol?
Well, that's where we get our strength. And I don't mean physical strength, but our inner strength. None of us are an island, and everyone needs someone to lean on, whether that's a spouse, children, friends, your religious community, your actual community. When you isolate yourself, you also are going to make yourself ill. That we are social people, and we need to have other people around us for our own health.
When we're thinking about the star, we've talked about this one side, which are the professionals that are the consultants. We've talked about the people in your life who are important to you and are crucial to your care and crucial to your life and to your satisfaction. There's also on top the MS job. That may mean getting reasonable accommodations. We're very blessed to live in the United States. I've got to tell you, having just come from Europe, you realize how much the American with Disabilities Act has changed things in the United States. When you have cobblestones and people can't move through streets and you don't have access to things, you realize how different it is in much of the world, even in the well-civilized Western world. But sometimes you may not be able to do as many reasonable accommodations because it's time to apply for disability. And so the MS job really means those two things. It means when to inform your employer. It means what reasonable accommodations to ask for. And then it also means at times to think about disability if that's something that's necessary. And then the base of that star is the MS community. And the MS community is a rich community of large and small not-for-profits. It's support groups. It's big groups, it's small groups, it's groups online. There's avatar support groups where people who feel more comfortable to just be online rather than in actual physical locations. There's the amazing things that MS Views and News has been able to do with this idea of being able to bring to people throughout our great country, be able to bring them information that hopefully is less biased, hopefully is more what you're seeking, and be able to hopefully to bring people together. Like Jeff said, look around the room. Did you see someone else not raise their hand before that they came with someone? Go and meet a new person. Go and figure out how you can really interact. And it's only through that interaction that I really believe that these individual M-stars that I talked about can really form a network together and form what I call the multiple sclerosis patient network. And the idea of MSPN is that the only true people that are going to be able to help other people with MS are people within the community itself. This idea of people with MS helping other people with MS. And that's the only real way that we can take the multiple sclerosis team approach rule and turn it into the multiple sclerosis team approach reality. For about a decade, I talked about that, but it never really hit home until Hurricane Irma. Hurricane Irma made me realize several things. One is, if you ever seen a movie with Armageddon, it's going to be so much worse than that. My wife was going to fill up on gas, and to fill up on gas, there was a line. You have to go inside and pay. You couldn't use the pumps. When you use the pumps, you had to go inside and pay. She had a person honking and swearing, and he had a small child in his car, as did my wife with our 2-year-old. She goes inside to pay, and she's a little nervous because there he is. And someone in the line goes, "Oh, I'm an attorney. That guy, he's a school teacher." School teacher. Regular good people, when stress happens, have a choice. And it's a choice we make every day when we wake up. Do we want to be like that person? Or do we want to be like the people with multiple sclerosis who around Florida lent a hand to each other? We had a woman in Tallahassee, and people started writing online, "We know someone in Tallahassee. Do you know anybody there who can help her? She needs some assistance." We had a person who was in a power wheelchair outside of Orlando, Florida. People came to his house, strangers came to his house when there was a threat of a hurricane hitting Orlando, and they helped him move things up into his attic to try to make sure that they're away from what we thought was going to be the ensuing wave and flooding going on. People had a choice. They could have acted like that one person who was a school teacher, or they could have acted and helped and lent a hand. And lending a hand is not just good to other people. It's actually good for yourself too. We talk a lot about this idea of mindfulness nowadays, this idea of being in the present moment, how important it can be. And there's been studies that have shown that it can be beneficial for individual symptoms of MS and for MS overall. There's nothing as mindful as actually going and during the moment, instead of thinking about yourself and all your bills and all the problems you have, going and helping another person. I think each of us can wake up every day and think about how we can be like that man who was the school teacher who was nasty. Or how we can show the true spirit, the true Pittsburgh spirit, and be like those people who helped each other. Carol, you've given us an amazing, I think every time, inspirational view of multiple sclerosis. And I really want to thank the nursing field for how much nursing really has embraced multiple sclerosis in a way that we haven't seen from other fields. Sure, neurologists, we're trained to be subspecialists. This is what we do. We think about the immunology, and we think about the T cells and B cells and all these scientific terms. But it's really the nursing field that has taken multiple sclerosis in the United States and taken it to a whole nother level. So I want to thank you.
Well, thank you. And I really want to thank the physicians now and other providers, the physician's assistants that have embraced nurses. And it truly is that nursing has become more like medicine, and medicine is now becoming more like nursing. It's a great mesh. I think it's wonderful that it occurred before the end of my career, that I can see that no longer is it a one against the other. It's a common goal, and we just want to make things better for our community, and our community includes people with MS.
We want to open it up now to questions. Please allow Stuart time to take the microphone over so that other people can hear the question, and we'll go from there.
Why don't we give these two a round of applause? They did great together. All right, who's up first? Who's up? Anybody got a question? I know you got a question. Mark, come on.
Come on, Mark. I know you have questions.
Really, you've done a great job. Thank you. No, I haven't, but I've listened to Carol numerous times.
Okay, great. All right, anybody on the left side? If not, I got a question to start them all off with, all right? Going a little bit away from what you were even just talking about, tell us if anything is out there yet with regard to biomarkers.
So excellent question. So the greatest unmet need in multiple sclerosis is not the next treatment for relapsing forms of multiple sclerosis. Every year we're going to see 1 to 2 new medications come out for relapsing MS, and we're going to see medications come out for progressive MS. We don't have a simple blood test to tell us always who has MS and doesn't. We have some blood tests coming out. We don't have a simple blood test that tells us how you're doing. We certainly don't have a blood test that tells us which medicine to pick for you at which time. So the idea of a biomarker is something that is fast and cheap and not too painful and can give us an idea of where you are in the world of multiple sclerosis. So I just returned from a week in Paris at the European Committee on Treatment and Research in MS. What we heard about there was about different aspects of multiple sclerosis, including the idea of biomarkers. There are several lab tests that are entering the field and that we're going to see more of. One of them involves this idea of neurofilament light chain. It's just a fancy way for saying that when nerves get damaged, when the wires, the axons get damaged, it deposits debris. The way we used to be able to test that debris is by doing a spinal tap. Now there are some blood tests that look like they match up pretty well with that, and can we find that debris even in your bloodstream? This is not so much for the diagnosis of MS, but for following MS over time. That's an example of a biomarker. There's a company now that some people may have seen online that offers a test called Isolate MS. And the idea of that is that they use machine learning to try to separate who has MS and who doesn't have multiple sclerosis. And now your MS doctors from around the country are looking at that information, trying to figure out where that can be beneficial for us or where that can't be.
I wanted to expound and ask, so are they looking at these biomarkers to look at, say I've been on one medication for so long? We all know that just a relapse doesn't necessarily mean as much. You can have things going on in your brain. Can they use this blood test then to look to see if you really are a responder to that medication? Or is it just going to be for if you have MS or don't have MS?
So the Isolate MS test right now is for the diagnosis. Maybe in the future it'll be for following people over time. But the neurofilament light chain research is definitely about following damage over time, seeing underneath the surface, not just the obvious things. A relapse is a very large inflammation that happens. There's a lot more that happens in multiple sclerosis than what happens in an MS relapse. An MS relapse, remember, is defined as new or worsening neurological dysfunction referable to the central nervous system that happens and is not preceded by any change for the 30 days prior to that. I know a lot of people that aren't stable in the 30 days prior to that, but then what do you call that new thing that's happening? And what do you call what happens 2 days later? That's not called a relapse according to the definitions. And so there's a lot more going on. There's low-lying inflammation that's going on, and that's where potentially blood tests could help us see under the surface.
Great. See, that worked.
Do you think that they will come out with a drug that's going to help with the remyelination? If I'm saying it right?
Yeah, so you're saying it absolutely correct. The question was, do I think there's going to be a medication to help with remyelination? So what does remyelination mean? So myelin is that fatty area over the nerve, over the axon. It's made by a cell called an oligodendrocyte. Interestingly, there's myelin also in your peripheral nervous system, but it's made by a cell called the Schwann cell, a different type of cell. That's why there's differences between the central nervous system and the peripheral nervous system. So if in MS what you have is damage to your myelin, demyelination, and you also have some axonal loss of problems with the wires themselves, well then what can we do to make new myelin, to remyelinate? Our bodies naturally remyelinate. That's why it's called multiple sclerosis, multiple scars. Think about on your skin. When you have a scar, that's showing that there was healing. That's what you see when we're seeing the scars of multiple sclerosis. We're seeing past damage followed by remyelination. The real question is, can we accelerate that remyelination? And that's what we're trying to do with remyelinating agents. There's the first one that was looked at in a major way in larger trials, which unfortunately had a positive report on the press release, positive title. And if you read the press release, it became less and less positive as you went lower and lower down. And that medicine, although they're still looking at it a little bit, will probably not be developed as a remyelinating agent. There are other medicines that are in phase 1 and beginning in phase 2. And what that means is phase 1 is the first time human beings get it. Phase 2 is safety. And phase 3 are the big trials. So earlier on that are being looked at in remyelination. In fact, there are several sites throughout the country and throughout the world that are trying to look at common generic medicines that are already available for other conditions and say, can those cause remyelination? We certainly know that if you calm down the inflammation, so if you calm down the attack of multiple sclerosis with the approved disease-modifying therapies, you're allowing your body to cause remyelination. So absolutely, there will be medicine specifically for remyelination.
Dr. Kantor, could you talk about not just remyelination, but what's being looked at for the actual axon being dead or gone, black holes?
So absolutely, great question. She used an unfortunate term, and although it doesn't sound like jargon, it is probably my least favorite word, worse than jargon. Unfortunately, when you look at an MRI, sometimes in an MS lesion, there can be white areas, there can be regular gray areas, and sometimes it's darker. The correct scientific term is a T1 hypointensity. Hypo meaning low, intenso meaning lower intensity. Unfortunately, some people in the field started calling them black holes. I think it's an unfortunate term because I think there's stigma attached with that word black hole. Right? We think of black holes, we think about the universe, and we think about things being sucked into them and other kinds of things. I really don't like the term black hole. And also, it doesn't really mean black holes. There's 50 shades of gray. There's a lot more shades of gray inside a black hole. 2 days ago, I was talking with some neurologists in Paris, and they actually were a little bit dorky neurologists. They asked each other, how many shades of gray are there in a black hole? And the answer is actually 256. It's actually a very correct mathematical explanation. Because remember, these are pixels. It just has to do with the pixel size. So you can't have every color in the world, but you have 256 possibilities of the shades. So there can be gray holes and there can be light gray holes. And what that means is not every black hole means that there was irreversible loss. Most of it means that there was damage that can then later be repaired. And one of the ways it can be repaired is exactly what you said, by remyelination. Because what you're doing is by forming new myelin, you're forming scaffolding on the outside of the nerve. And then with that scaffolding, the axon itself can grow. So it's difficult for axons to grow and it takes time, but they can grow if they have the proper nutrients and the proper scaffolding. So absolutely, as we develop remyelinating agents, we may actually be creating agents at the same time that actually cause axonal growth.
New question, please.
I think you might have answered it, but my husband is the one that has the MS. And a number of years ago, we went to a neurologist because we didn't know what was wrong with him. And they told him he had MS, he had a lesion in his head. But then you were mentioning this blood test to see if a person has MS. Am I mistaken that it's the lesion that tells you?
So it's actually neither the blood test nor the lesion. MS is a clinical diagnosis. It's a diagnosis based on central nervous system dysfunction. What I mean by that is it's not something that's like, it's not the tingling that you get with diabetes. It's a different kind of tingling, but it's not that same kind of tingling. It's from the central nervous system, so from the brain, the optic nerves, or the cervical or thoracic spine. And then what happens is there's going to be something that happens, and then later on, there'll be something that happens perhaps in a different part of the body. So one time someone may have weakness, and another time eye problems. So not the same thing over and over. That idea has been consistent for the definition of how we diagnose MS. Now, there are things we can do to make the diagnosis faster. MRI has revolutionized our ability to make the diagnosis of MS faster. The new criteria are coming out this year for MS called the McDonald criteria, the 2017 version. And they're going to include, once again, lumbar punctures or spinal taps to help you make a diagnosis of MS even faster. So really, with one attack and a positive spinal fluid, you can make the diagnosis of MS immediately where you couldn't before technically.
Well, then
So
how do we know?
Well, the blood test we were talking about is hopefully in the future that it would be something that could be done.
Now, he had two neurologists that said that he had the MS, okay? But the first one tried something and he said, oh, you're too old, nothing will help you. So we let it go, and of course, his progressed a lot in different ways. So that's kind of bad, that he said that.
As time is going on, we're getting better and better at diagnosing MS earlier, and we're getting better and better at taking people more seriously. It's unfortunate that in the history of MS, I remember meeting a federal judge, and it took her 13 years to get diagnosed. People didn't take her seriously, even though she's a federal judge. Partly she's a woman, partly she had non-specific complaints. It took a long time for the diagnosis to happen. And then unfortunately, there's still some pockets of this country, especially doctors who have practiced a while back, who are nihilists or push away the idea that medications can help, where we do know from study after study, and in fact there's been newer studies released last week, that even our regular medicines for relapsing forms of MS can stave off secondary progressive multiple sclerosis as well. So we are getting better as a community at understanding these things better.
No question.
Going back to remyelinating, let's assume that there is a medication that will remyelinate. Does that mean that there will be transmission of the nerves, of the messages, and the whatever will start working again?
So the question was, let's say you take somebody who has loss of myelin and you put new myelin on there, is it going to suddenly make the nerves work? Well, at a certain point, there could be nerves that are too far gone, but if a nerve is still able to put myelin on top of it, then what's going to happen is you do expect there to be faster conduction down the nerve, meaning electricity is flowing better, flowing more smoothly. We heard Jeff talk, for example, about a medicine that's approved for walking in MS, and the idea of that medication is actually to make the myelin work more normally than it was working before. The idea to make the nerve conduction work more normally than it was working. It's not to make new myelin, but it's more functionally to make that conduction work. And so yes, the hope of remyelination is that you're able to take nerves that aren't transmitting as well as they should and make them transmit better. Now, if a nerve is not transmitting at all, so if it's no longer there, well, then maybe the myelin, by making that scaffolding, can make that nerve grow, but we are going to need other nutrients to make and stimulate that nerve growth at the same time.
Might therapy be required to help that process along?
Therapy is always useful. Physical and occupational therapy are always useful for multiple sclerosis. They can help you in exercising more safely. Not everyone is blessed to have somebody like Jeff Siegel, a personal trainer who's as knowledgeable as he is. And so generally, physical and occupational therapists are more knowledgeable. And what have you found here? How does it matter where the physical therapist comes from?
It's really important to, when you make an appointment with a physical therapist, to make sure that you say, is your focus neurology or is it sports and physical medicine? There's a big difference between an orthopedic physical therapist and not. But I really like physical therapy for patients. It builds muscle memory. Just like exercise, I can't stress that enough, how important that is. And I know you're tired, and Jeff said you're tired, but it actually decreases your fatigue when you exercise. But that's the biggest thing. Ask when you make the appointment, is this a sports medicine physical therapist or a person with a neurology focus? You want a neurology focused physical therapist.
If you read an interesting research study, what would be the best way to talk to your doctor about it? Should you print out the paper and bring it in?
Excellent question. Let's hear from you, Carol.
Well,
what do you
first
suggest?
is a lot of the all the information about any research study is on. I just lost it. PubMed, but there's also .gov.
Well, clinicaltrial.gov.
Clinicaltrial.gov. And you can type in MS and all the trials will pop up. The thing to remember, if they're not being done here in the area, it's very difficult to get into a trial in San Francisco because there's a lot of patients in there and they have already filled with their own patients. But clinicaltrial.gov is a great place. I know between the two systems, we do share patients for research. The two large centers do a lot of MS research, and we send people back and forth.
But that's an excellent question. And I think the question was, if you find something you're reading that sounds interesting, how do you let your doctor know about it? Should you just say to them? Should you actually print it out? Should you print it out from Google? The best would be to print out, if you can add the actual article. So when I say an article, I don't mean someone's opinion on a blog. I mean, if you can get the actual peer-reviewed article, that means that other people, that's the idea in medicine, things go through a process where peers, so other doctors go through the data and say, does it look right? Does it not look right? Is there fraud? Is there no fraud? Scientifically, are there mistakes or are there not mistakes?
Is there a trial you were looking at recently that you were interested in? Is that what?
I was kind of thinking about in general with, psychiatric, difficulties even, I've struggled with that, and, I've read interesting things, and, I've questioned, what the doctors have, sort of talked about.
There are neuropsychologists in the greater Pittsburgh area that specialize in MS and identifying the problems associated neurocognitively, neuropsychiatrically with MS. So that's one place to look.
A wise person recently told me that if you hear about a research study going on, or if you read one going on, don't just say that, or just don't believe that somebody says, hey, I heard about this research. But is the research really titled? Is it by somebody, whatever? And like the doctor was saying, and like Carol was also saying, that it's got to have a study connected to it, and don't just go by hearsay.
How you doing? I'm a current care partner of this fine woman next to me and future husband. But I'm going to, what? Okay, come on. In any event,
I allow it.
I got two questions. Okay, actually, the first question is this, because you touched on a lot of bases on the care partner stuff. Okay, how many people would you be comfortable with at one time being in the office, okay, with the actual patient in order to get information, being that, and I think it was you, doctor, who touched on this, the amount of time the physician has to answer any questions. It seems like you guys sometimes are quite rushed, okay? And insurance companies are cutting more and more and more time from any doctor, that is, to answer a patient. MS patients already have cognitive issues. If they're rushed through their appointment and a couple caregivers are in there, we're rushing just as much for them to obtain the information that you're giving to the patient. So that's my question for you.
How many people are inside the office room depend on what needs the person with MS has? Who do they need to have with them? And also, frankly, depends on culturally. So I practice in Southern Florida. If you're from a family from South Florida, from different ethnicities, you may have the mother there, the father there, the grandparent there, the cousins there. You may have everyone except for the cat or the dog in the room with you as well. It just becomes a cultural issue of how many people are there. I do think it's important beforehand to have an idea of what you want. You don't want it to be at the office visit that there's a cacophony of speaking and no one has an idea. You want the person with MS hopefully to be the person controlling that office visit.
You also, this is the preparation portion prior to the appointment. The 3 most important items need addressed. That should be with the other people, the care partner, the care team. It's not their 3, this 3, this 3. A discussion occurs. What is the most important thing that needs to be, it's not so much how many people are there to listen, but it's what 3 most important issues need answered.
We have time for just a few more questions. It is getting late. Oh, that's right. I will be back to you in a second. Actually, you first. Sorry about that, guys. She's been waiting.
What are your thoughts on chiropractic care for the MS patient?
The question was about chiropractic care for MS patients. What do you think, Carol?
Not being a healthcare provider, but a healthcare supporter. I provide nursing care. That's between the physician and the patient, or the healthcare provider, nurse practitioner, physician's assistant, what works and how they would go about that. I personally, as long as they're not cracking your neck, I don't think they hurt you that much, but I don't. I have seen tragic issues that have happened in our practice of patients who have succumbed to having their neck cracked.
Yeah, well, my lesions are in my neck, so I would not let them touch that area.
Well, a chiropractor isn't going to be able to fix lesions anyway.
No, I know that, but I would not want to take the chance of anything happening.
I would really recommend a massage. More so.
Question here, please.
Yes. First, I wanted to say I do agree with the nurses are awesome, and plus the one lady answered my myelin question I wanted to hear. But is stretching like more important when you do exercises, or will it like wear you out where you're fatigued for the rest of the day?
The question was about stretching, and when you're stretching, will it help you with your exercise or will it wear you out for the rest of your day? Well, it depends. If you've not done stretching before, then stretching can be something that feels like it's exhausting. But and all that tells you is you should start stretching a little bit, get a little better at it, then come the next day, do a little bit more stretching. Then comes the next day, you do a little bit more until it becomes something that's routine for you, and then on top of it, you add the exercises.
And the other thing to remember, there's a major, major difference between MS fatigue and I'm falling asleep during the day. If that's what's happening, that you're extremely drowsy and falling asleep, you need to bring that up with your healthcare provider, because a lot of people with MS have sleep issues, and that's a sleep issue. If you're falling asleep, that's a sleep issue. That's not MS fatigue.
New question.
How do you feel about the CBD oils and the medical marijuana?
I didn't ask her to say that.
Marijuana is against federal law. There is no such thing as legal marijuana. Different states have taken different stances against federal law. There is no such thing as medical marijuana. Medical marijuana is like saying medical alcohol. Sure, you could drink enough gin that eventually I could amputate your leg and you would not feel much of it. It's, in fact, how most medicine worked in the Civil War era. With that said, some people want to know, are there benefits to the idea of the plant? And so can the plant that has both cannabinoids as well as THC, can that be beneficial to people with multiple sclerosis? So the first question is, can it be disease modifying? The answer is we do not have evidence that any plant is disease modifying. The only evidence we have are actually those 13 separate branded products, 1 branded generic, and 2 unbranded generics. It's not for a lack of trying. There's been very, very good studies now, more and more, looking at complementary alternative medicine. It just hasn't reached the level of being able to modify MS. Help symptoms, yes. But modify MS, no. So then specifically with marijuana, what can it do in terms of the symptoms of MS? In fact, MS is one of the things that there's the best evidence for of almost anything. Many people may have seen the CNN special and people with supposed epilepsy who have had benefits from CBD oils. It's interesting because when you look at the actual scientific literature, epilepsy is one thing that marijuana has not been shown to help. In terms of MS spasticity or muscle tightness, people with MS, some of them do self-report a benefit in terms of the muscle tightness. Interestingly, when the doctors did what's called the modified Ashworth test, so an actual objective or a more objective test of measuring people's muscle tightness, it did not show a benefit. It was a self-reported benefit, which is different than objective benefit. So is there something there? Possibly. Do we need more research? Absolutely. Are we hurting the chances of there being research when we go state by state and in various levels legalize it? Absolutely. Because if I was a pharmaceutical company and I had a compound that was interesting, would I develop it if I knew that people could just go out and smoke marijuana? No.
Well, and the thing to remember, Pennsylvania has a very, very strict law that is in place for this, our Pennsylvania's medical marijuana law. First is you cannot go to your neurologist at your regular appointment and say, would you sign my form stating that I have a condition that allows me to get medical marijuana in the state of Pennsylvania. And that's because your insurance is paying for that appointment. That is against federal law. So you will need to make a separate appointment with a physician, pay cash. You cannot write a check. You cannot use your credit card or your cash card. You must pay cash, green dollars, for that appointment.
Does that sound concerning to anyone? To get drugs, you're going to have to pay cash. I'm just saying.
So, I mean, and it is not going to be covered by your insurance. Once that appointment is completed and a physician has signed off that you have one of the 17 qualifying disease states in the state of Pennsylvania, you will then go to another facility, see a physician in that facility, pay cash, do not write a check, do not use your bank card, pay cash, to then him to verify that this was a physician that really did sign your form, then you're able to buy the drug. It is not on your insurance. It cannot be written by a check. It can't be paid by your bank card. It is a cash deal. And that's because marijuana is not legal federally. There's also a requirement that the physicians to sign your form in the state of Pennsylvania will need to take 8 hours of mandatory education that is not reimbursed. There's not many neurologists in the area that and I am very up with all the neurologists in the area that have decided that they would do that. They are hoping that pain management will take that portion over. But those are things that you need to know about the Pennsylvania law.
Any new theories on what actually triggers MS?
Excellent question. Saturday morning of the conference was the most exciting morning because it was the late breaking session. So you saw some trials where we finally saw the results. I've got to tell you, frankly, nowadays in medicine, most of it's boring. You know why? Everything is released by press release for the sake of the investors in the stock market. So by the time we come to a scientific meeting, we already know the results. We may not know every detail, but we know the basic results the same as the investors know. Oftentimes they hear before us. But there was a presentation on a trial called Change MS. What's important about that is not the compound they used, but the concept. The concept that was being explored there is that while we are looking on the outside for what causes MS, we should have been looking inside. 8% of our DNA is actually not human. It's originally from a virus millions of years ago. And that virus lurks inside us, doesn't cause problems. And in fact, we think that viral DNA is what's important for implantation and fertilization when you're going to have a baby. But sometimes there can be pathogenic or problematic proteins that come out and are encoded by that DNA. An example of that is what this was a trial of, which is called HERV-W envelope protein. HERV is human endogenous retroviruses envelope protein. And so the idea is, can you block this protein that's produced by this DNA that originally was not human DNA, but it's been in our DNA for millions of years? And unfortunately, in August, we had a press release that said that it was a negative 6-month trial, and we're waiting for the 1-year results next year. But then on this past Saturday, we heard that although it was negative, it was only negative because we expected it to work faster. What we did is we looked at the MRI changes and we said, let's accumulate every change from the baseline till month 6. When you do that, it wasn't what we call statistically significant, so you couldn't be sure it wasn't by chance alone. But if you looked at month 6 versus your baseline, we did see a benefit. What that means is perhaps we're looking for an outside virus that causes MS, and we're looking for genetics of MS, and maybe it's all one and the same. Maybe that virus is actually already inside us. And then some sort of early environmental exposure triggers that to happen. And perhaps there's other environmental exposures that make it easier. If there's low vitamin D, that can make it easier for that virus that's inside us to get reactivated. If you've been exposed to the Epstein-Barr virus or mono, that can make it easier. And if you do the worst possible thing that you can do for your health, which is smoking cigarettes, that can lead to an earlier age of diagnosis, more relapses, more progression of disability, and if you're still on self-injectables, more skin site reaction as well. So we are having new ideas of what may cause multiple sclerosis.
Well, I want to thank everybody for coming here today, and I want to thank the two of you especially for doing a great job. I'm sure they all got some education today. Thank you again very much. Thank you again very much. What did you all think about this? Did you have a good time with the program today? Did you learn something new? Did anybody not learn something today? Is there anybody? Everybody's okay with that? Does anybody want to see what I was supposed to do today? Well, watch this. Are you all happy?
Oh my gosh, I love it.
That's what I was supposed to do today. It wasn't supposed to be as Batman. I was supposed to show up like that, okay? All right. So anyway, I have a question, and this is very, very important. We're not scheduled yet to come back to this area again next year. I need a round of applause to see. I got to hear it if you want to see us do another program in this area. She's not clapping. She is not clapping over there. She's smiling, but she's not clapping. All right. Anyway, I'm going to ask you all to make sure you fill out those seminar evaluation forms, please. We need to see what you want us to bring to you next year, all right? Do you want us to do a program similar to this? Do you want us to have same speakers, different speakers? If you want to hear us talk about anything other that's, again, not specifically about the MS medications, we would love to do programs for you, maybe about urology, maybe about psychology. The impact of MS on the family is a great topic that we could bring you as well. We do neuro-ophthalmology. Yeah, it's just endless. Obviously. I mean, just see how you feel and let us know what you would like us to bring you. Okay? Again, thank you, everybody, for coming here, and I greatly appreciate it, and I do hope to see you all again. Thank you.